talk. Well, I think that we've gone over the role of thermal imaging. We've gone over what sympathetic pain syndromes are and what they're not. We've gone over how to diagnose and vasomotor map what sympathetic pain syndromes are. Now I'm going to try to talk about what's the generator of that pain, give examples of different structures that can generate a sympathetic response, and that we don't want to just treat the symptom, we want to treat the source. So block selection is arbitrary if you don't know where or how up or under what distribution you're getting that vasomotor instability. So why be arbitrary in our block selection when we can monitor it and we can measure exactly where the source is coming from? So in addition to the SCSG block, we also do the sphenopalatine ganglion block. Does it really make sense if you have an ophthalmic condition or Beret-Liu to do a stellate block when you know you've got a lot of vasomotor changes in the eye and face? It may very well make sense to do a stellate block, but why not block above and treat below? So let's give some examples of different generators, different case histories, if you will. This is a woman that had a RSD of the left upper extremity after a degloving injury. So you can see she's got a mauled hand here, and it was in particular of the thumb. But she also had a comorbid brachial plexus injury and ulnar neuropathy. We're not able to get a relief from any stellate blocks, sympathetic blocks proximally, but when we did the thermal imaging, we were able to see that she had an extremely cold asymmetry pattern and distribution of the ulnar nerve, and actually what gave her relief was ulnar nerve block at the elbow. This is a case of RSD of bone. This person had a first through fifth metatarsal fractures of the foot, had all kinds of treatment directed towards the foot. We did thermal imaging. You can see that the entire limb was involved, and we were able to achieve relief with a lumbar epidural steroid injection. This is what I would call a classic distribution of dural pain, the dura itself. As I've coined the word, I think Dr. Schambach and I were talking about duropathies. The dura itself is C fiber mediated. This person had been diagnosed with persistent floating left rib pain, and it was a cervical epidural that brought them relief. The disc itself is C fiber mediated. This person has a C67 HMP, and as we see, they have an asymmetry pattern on the dorsal and radial aspect of the arm and forearm. They had been offered an ACDF, but they declined it. A stellate block and a catapress patch was able to bring them relief. The siniovertebral nerve that supplies the facet itself, the posterior primary rami, many of these people have posterior primary rami syndromes, are very, very rich in C fiber innervation. So here we see localized cold spot at the L5S1 region. It was a fell back syndrome. However, they also had this localized hot spot at L3-4 and responded to facet region blocks at both locations. This is a failed back L5S1 discectomy that had, in fact, a piriformis syndrome, had intense hypoperfusion. We did both a piriformis origin and insertion injection, blocking at the sciatic nerve prior to treating the source. This is an example of a ligament being the source. This individual had RSD of the right lower extremity. He had status post-medial meniscectomy and an ACL repair. We found an asymmetry pattern involving the entire limb. Did a lumbar sympathetic block. First an epidural to quiet down the inflammatory response, followed by C fiber block. And I know Dr. Argawal knows this, but in Europe we don't block things, we restore things. We call it in the United States, we're blocking it because we're changing the transmembrane potential from -70 down to 90 or 120 so that it never reaches threshold at 130. I'm a big believer in the fact that we're not blocking anything. We're restoring transmembrane potential, and if the body is well enough to maintain it, once you reset it, then it will hold it. And that's why some blocks last and some don't. And if they don't, you should be asking yourself all the other questions we went over. Why isn't this person getting well? Infection, inflammation, coagulopathy. What can you do to reduce total load? Vein itself can be a generator. This is a person with right lower extremity RSD after saphenous vein stripping. They had a dystonia. As you can see, they have abnormal posturing. The first thing we did is treat the posterior tibialis with botulinum, and then followed that with femoral nerve blockade. Skin itself can actually be the generator of the sympathetic response. This is a person with right upper extremity RSD after having a dog bite to the forearm. Took some time to figure this one out. There wasn't that much of a change. There is some change above the elbow, but there's a rather dramatic change below the elbow, and there was also a change in the distal dorsal aspect of the arm. We did a combination of ulnar nerve block and radial nerve block, and that's what provided this patient relief. So block above and treat the source. Block above and treat the source. Stop the sympathetic response, treat what's causing it to generate. By definition, it's a car engine that's dieseling. You've got the key in your hand. The car is still running. It's dystrophic. It's not normal. But if you can quiet down that dieseling and treat the source, there will be cases where it will stop dieseling. And why miss those? Those are people you can turn around. You can actually reverse disease. And the source may be comorbid disease. This is a patient that had a Morton's neuroma resection ×2. They had a prior history of diabetes, hypertension, and venous reflux. We provided sympathetic block in L4-5, followed by treatment of the comorbid conditions. Can't get blood flow into those tiny little blood vessels. This person has vascular disease. Treat their vascular disease and get some blood flow going throughout the whole system. And you may find that blocking above, in fact, does treat the source. So here's an individual that had adhesive capsulitis, frozen shoulder syndrome. We did the thermal imaging, have an asymmetry pattern of C5-6 distribution. A C5-6 paravertebral block provided full shoulder range of motion. We may block above and treat below. This is an individual who had right elbow pain and was considered for a tenotomy, was afraid to undergo the procedure, came to have seen me and told me that she had a prior history of Raynaud's. And in fact, we found that she had second and third prior history of vasospasm. We did the thermal imaging. We're able to do a stellate block and followed that with an ultrasound-guided percutaneous tenotomy and brought lasting relief. Sometimes you have to treat associated disease, and the disease itself is worse than the dystrophy. This person had a prior diagnosis of left lower extremity RSD, but when we did that sympathetic skin response study, we found that it wasn't the foot that was the issue, it was why is this person's calf warm? I re-examined her, found that she had a positive Homans, did a venous duplex. She had grade 2 stenosis in the popliteal vein. She had a coagulopathy workup that showed a positive D-dimer and elevated antithrombin 3. She was treated with low molecular weight heparin and got full relief. As Dr. Brioche and all the others have talked, fibromyalgia is not a singular disease. It's a disease of multiple other problems. At least 2 out of 3 fibromyalgia patients will have weather-sensitive pain. I think that after this morning's talk, all of us will be more acute and aware for that. I know Jeff is waving at me. It's time for us to break. We will start again promptly after lunch at 1:30 in this room. Thank you very much.